And we are live on Facebook as well. Feel free to start on the hour, Dr. Bodeman.
Hello, it's 12 noon, and I would like to welcome you all for joining this week's Medicine Grand Rounds. Today we have two speakers, Dr. Monica Dand and followed by Dr. Matthias Iberico. Dr. Dand is an assistant professor of medicine and co-director of Resident Initiative on Global Health at Tulane. Dr. Dand completed her internal medicine training and chief residency at Tulane and her tropical medicine training at London School of Hygiene and Tropical Medicine. She works with NGOs, including Médecins Sans Frontières, on humanitarian missions in various international contexts, and she's a teaching hospitalist at University Medical Center in New Orleans. Dr. Dand will be followed by Dr. Matthias Iberico, who completed his internal medicine residency training at Kaiser Permanente in San Francisco. He then spent 2 years at UCSF HEAL Initiative Global Health Equity Fellow, rotating between Fort Defiance, Navajo Nation, where he worked clinically, and Bamako, Mali, where he worked with the nonprofit Muzo on community health worker training programs. He's passionate about global health equity, and for the last 2 years, he has supported development of household model community health workers program in rural Chiapas, Mexico, for the nonprofit Compañeros en Salud, and more recently has been helping to plan their COVID-19 response. He also co-teaches a course on health and human rights at Tulane School of Public Health and Tropical Medicine, and teaches on the wards at University Medical Center as a hospitalist for Tulane. He's a co-program director for the Right Resident Initiative in Global Health at Tulane program. I have a pleasure, it's my pleasure to introduce Dr. Dand to start the discussion, COVID-19 update, a humanitarian perspective. Thank you for joining us today.
Thank you, Dr. Bodeman. Okay, so I'm going to start. No conflicts of interest to report. These are the objectives for the talk. So I'm going to do a brief introduction on humanitarian aid, including global health equity and the Sustainable Development Goals. And then we'll talk about the structure of the humanitarian response and compare that with our current pandemic situation in COVID-19. Talk about the limitations to the response and secondary effects of a humanitarian crisis. And then we'll talk about a current COVID-19 multinational humanitarian response. So to lead off, I'm going to start with the Sustainable Development Goals. The Sustainable Development Goals are kind of a broad set of goals that were developed by the UN General Assembly in 2016. And these goals are 17. They have 169 targets, and they're based on 3 pillars of economic development, social equity, and environmental protection. You can see that goal number 3 is good health, which is the one that we'll focus on. But this is kind of what guides all humanitarian aid and global health and public health on an international scale. This is slightly different than the goals, the Millennium Development Goals from the year 2000, in that now the focus has shifted from less of a foreign aid from wealthy to developing countries, and more of a universal set of goals for everyone. So these Sustainable Development Goals were approved by 194 member states, and they are they're not exclusive goals, and they focus more on the social determinants of health. The WHO, I'm sure you all are familiar with who the WHO is. You can see to the right, goal number 3, the Sustainable Development Goals, is good health and well-being. And there's a series of targets that are addressed in this, including reducing the global morbidity and mortality rate to less than 70 per 100,000, reducing mortality related to non-communicable diseases, promoting mental health, and also achieving universal health coverage. The World Health Organization has a mission to attain the attainment of by all peoples at the highest possible level of health, where that definition of health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So the role of the WHO is mostly in public health, and research stimulation, generation, and most importantly for our purposes, monitoring trends and health situations, especially as it relates to outbreaks. So the WHO is a specialized body of the UN, and it coordinates with the 194 member countries, so almost all countries in the world. But unfortunately, it doesn't really have very much power, so it can't actually bind or sanction any of its members. It can give recommendations, and it does have a large budget, but that budget includes an incredible number of research and public health projects. So really it relies on individual countries' transparency and their willingness to cooperate with recommendations for public health measures in an outbreak situation. And if we think about some recent outbreaks, SARS is actually a good success story. So in 2002, SARS was initially found in China. And maybe it took a little while for the WHO to be made aware. So in February of 2003 is when the WHO was made aware. And then after that, China seemed to cooperate very well with WHO. And we would count as a success story because despite it progressing to 26 countries, there were less than 1,000 deaths. And it seemed like in that situation, the public health measures were the thing that were the most effective, not really any medication or vaccine. Following that, there were some international health regulations that were put in place in 2005. So it basically just kind of extended the expectations of individual countries to cooperate with the WHO, but still didn't give them any power to react if those countries did not cooperate. So we moved to Ebola in 2014, which doesn't seem like it's as much of a success story. The WHO was criticized for being very slow to react, and the countries that were affected, especially in the 3 countries in West Africa that were the most affected, actually had to request intervention from other sources, NGOs, militaries from other countries to intervene in lieu of the WHO. With regards to COVID, there has actually also been some criticism by of the WHO, specifically with regards to how everything started. And what the WHO has said is that there was a little bit of lack of transparency at the start of the outbreak, and the WHO was criticized for lack of pressure on China to begin with. Also, it seems that Western countries, US and European countries, although the WHO has tried to promote us preparing for pandemics over the years, there really hasn't been much progress in that arena. And we haven't been so compliant with the WHO recommendations, at least not at the start. So this was declared a public health emergency, an international public health emergency by the WHO in March. I'm just going to talk a little bit about the general structure of humanitarian response. So like Dr. Bodeman said, I work mostly with NGOs, specifically Médecins Sans Frontières, which is Doctors Without Borders. And the way that we respond to a humanitarian crisis, depends on a slew of different things, but there is actually a structure to the response. So when something happens, a lot of different organizations come in, and then we have to organize ourselves. So this picture on the right, you can see, is from South Sudan. In that situation, there was a conflict in Sudan, and so this is right on the border in South Sudan. A refugee camp behind the front lines, 50,000 people developed in a very short period of time. And the UN agency that responded to that was the UN High Commission for Refugees. So they coordinated with the South Sudanese government to help to structure this refugee camp. And then there are different sectors, each of which have a corresponding UN agency that's assigned to it. So sectors such as health, protection, water sanitation, nutrition, food security. Each sector has an NGO or multiple NGOs and local partners. So Médecins Sans Frontières is a health partner. And the things that we focus on are direct delivery of care and using our principles of medical ethics, impartiality, neutrality, independence, accountability, and transparency, and then also bearing witness to what's actually going on the ground. The context of a humanitarian crisis matters because it really affects what you're able to do. So in order to enter into any humanitarian crisis, MSF actually negotiates, and that can be more or less difficult depending on where you are. So certain conflicts are conflict zones, certain contexts are conflict zones. So for example, Syria, when MSF wanted to work in Syria, we're still there, but doing slightly different work than, or maybe in a slightly different way, just given access issues. We originally negotiated with both the government and the rebel forces, and had a very difficult time getting permission from the government to work there, and so coordinated mostly with the rebel groups. Same thing in Afghanistan and Yemen. Coordination and permission to work involves talking to all parties involved in an armed conflict so that they know who you are, what you're doing, and that you are in fact impartial and neutral. And because of that, we're able to work in places where other organizations are not able to go. Other contexts, refugees and internally displaced persons camps. So we have many of these camps around the world on the border with Mexico, Syrian, Afghani refugees in Greece, in Bangladesh, the Rohingya refugees, and then South Sudan, like I showed you the picture before. And actually, even if you think about people after Katrina, so maybe some of you all were internally displaced persons after Katrina. Other contexts, political unrest, so thinking about Kashmir, and then also Venezuela, and then environmental situations, so the earthquake in Haiti, flooding in Pakistan. This picture to the right is a picture from Bangladesh. It's a Rohingya camp on the border between Myanmar and Bangladesh. It's called Kutupalong Camp. And in less than a 1 week period of time, it ballooned from a camp of less than 100,000 to 1 million people. And so, there's very, very difficult living conditions, poor water and sanitation. And, you could call this a crisis within a crisis in the sense that there are a couple different things happening. So it's a refugee camp. There's some environmental issues in that it's monsoon season. And then there's also outbreaks on top of that. So a population who's already suffering, if you add another stress on top, it's going to be quite difficult for them to handle it. So vulnerable populations, in general, are going to have poor outcomes in any type of humanitarian crisis. And this applies to COVID in New Orleans, in the United States in general as well. So at-risk populations are intuitive, internally displaced persons, refugees, migrants, prisoners, women and children, pregnant women, elderly, immune compromised, those with disabilities, and malnourished people. And then also places and countries where the national health indicators are very poor. So these go back to the Sustainable Development Goals of health and well-being for all. These are some of the indicators that we look at to determine, how well a country is doing in terms of those goals. So health status, like infant and maternal mortality, preventable diseases, risk factors, so the rates of non-communicable diseases, and nutrition. Service coverage, is there access to vaccines, antenatal and postnatal care, mental health, neglected tropical diseases, depending on the location, and then is there access to safe and quality healthcare? So people who have, people who are very vulnerable have these poor outcomes, and more so than other people. So they can lead to food insecurity, education disruption, lack of protection of the vulnerable groups. Political changes are going to disproportionately affect these vulnerable populations. Any interruption in the supply chain will also affect them. And then sexual gender-based violence and intimate partner violence, child abuse and forced prostitution. We even see this in the United States, that the rates of domestic violence and child abuse have increased throughout this pandemic. And they generally increase worldwide whenever there is a humanitarian crisis, and those groups are going to be most vulnerable. So the global response to COVID, this is a set of strategies that's put out by the UN Office for Coordination of Humanitarian Affairs, and it's pretty general strategies with series of targets to meet each strategy. So, of course, strategy number one is to contain the spread of the disease and decrease morbidity and mortality through a number of different mechanisms. Strategy number two is to decrease deterioration of human assets and rights, social cohesion and livelihoods. And this is important in that it provides for continuation of necessary services that were available before the crisis. So nutrition, protection, food access, water and sanitation, and then focusing again on the supply chain. And then protection, assistance, and advocacy for refugees and other vulnerable communities, and then anticipating any safety risks that may arise because of the humanitarian crisis. This is certainly not the first time there's been an outbreak. There's been outbreaks before, and we do have some lessons that we've learned from those. CDC Africa actually came out of the Ebola outbreak in about 2014-15. So this was the African Union coming together to put together their own centers for disease control so they could better respond to countries on their own continent in ways that they thought were appropriate for their own communities. And instead of relying on help from the outside, as they did with the poor outcomes during the Ebola outbreak. The focus on public health, outreach, and contact tracing and community-led initiatives all have been proven to be the most effective ways to kind of structure a response to an outbreak. On the right, you can see some pictures from a diphtheria treatment center in Bangladesh. So I worked there a couple of years ago, and there was a diphtheria outbreak, and all of our staff were Bengali, and they built this diphtheria treatment center. So out of bamboo, we actually tried to use other structures that we would normally use, and the bamboo worked the best. On the picture to the right, you can see is our isolation ward for people who were in recovery after having received the diphtheria antitoxin. So of course, you can't talk about any of this without mentioning resource limitations, and this is a lot of what's in the news these days. There's a lot of different ways to think about resource limitations. Medication availability, I think, is one of the most obvious. So, I'll talk again about the diphtheria outbreak. So in the beginning of the diphtheria outbreak in 2018, there actually was a worldwide shortage of diphtheria antitoxin because there were no diphtheria outbreaks, or they were very, very rare, and usually just endemic cases, not outbreaks. And so in the beginning, NGOs and governments put international pressure on pharmaceutical companies to upscale the production of diphtheria antitoxin. But in the meantime, we had to triage and give only diphtheria antitoxin to under 5-year-old children. And so in the beginning, there were deaths that could have been prevented had we actually had that medication available. And comparing that, to the COVID pandemic, we have some shortages of medications that we've been using a little bit more than we normally do. So some sedation medications like fentanyl have been in shorter supply. Of course, options for airways. So this is, I think, the thing that's in the news the most. Which country has only one ventilator, in the whole country. And that's certainly true that there's not a lot of ventilators in many low to middle income countries. And actually the ventilators that are available are probably being used for surgeries and are not ones that can be spared for someone who needs a ventilator for 1 to 2 weeks for COVID. And then, not really many options for non-invasive ventilation. Referrals are a huge issue in many locations. So referrals to secondary, tertiary care. This past year, I worked in Myanmar on the other side of the border from Bangladesh with Rohingya. And in Myanmar, they actually are considered stateless. So they're not considered citizens of Myanmar, even though they've been there for generations. But because of that, they're also not allowed to travel. So they're really restricted to essentially a few mile radius that's surrounded by checkpoints, which they cannot cross. Even sometimes to access primary health care in the middle of the night, they're not allowed to do that either without government permission. So, any referrals that needed really anything else besides a community level hospital, you had to get, it was a few week process to get permission for someone to move. And even then it was frequently denied. This past year, I had a case of a child who had acute glaucoma. We wanted to transfer him to see an ophthalmologist, given that the risk was losing his eyesight. And he did actually get access after 1 week, but in the meantime, his father had to give up all possibility of him ever becoming a citizen of, a real quote unquote citizen of Myanmar. So sad case, but something that's very, very common. Supply chain, we mentioned this a lot, but this is in regards to border closures, but then also exports and imports. So, if the borders are closed, your supply chain is obviously going to be interrupted. But, many countries and many low to middle income countries rely on supplies that are produced by other countries. And if those countries are decreasing their exports because they're keeping them for themselves, because they themselves have to deal with the COVID pandemic, those other countries are not receiving the supplies that they need. If you think about places like Syria, Venezuela, places where the supply chain has been really interrupted, it's very difficult to access populations because of conflict and direct attacks on those supply chains by rebel groups and government groups, especially in Syria. Medical facilities, so just thinking about the basics, is there a medical facility? Is there capacity for isolation? Is there electricity and running water? Do they rely on generators? Is there even an oxygen concentrator that you can plug in? Can you sterilize any equipment that you use? And what about the morgue? Is there a capacity for many bodies if the mortality rate is expected to increase? All of these resource limitations are affected by not just availability, but politics, conflict, discrimination, and then just general location and environmental factors. When you think about facility, when I was working in South Sudan, I was about 45 minutes behind the front line, and there was one hospital that dealt with all the war wounded. That one hospital had one ventilator and one surgeon who was South Sudanese, who was responsible for treating all of those patients. And in order to get there, especially in the middle of the night, you had to cross multiple checkpoints with both rebel and military soldiers. And so to transport people there was quite difficult. All that being said, resource limitations can generate innovation. So there's a lot of things that low to middle income countries do that we don't think about doing. There's some few very small examples to the right. So at the bottom right, you can see our ambulance. This was, we didn't really have very many motor vehicles in the refugee camp in South Sudan. And so we used a donkey ambulance, which was actually very much more effective than I think a car would have been for getting to some of the places where we needed to pick up patients. And then at the top, you can see an incubator. So because there was a hepatitis E outbreak, we had a lot of pregnant women who went into premature labor. And so we had a lot of premature babies and ended up opening up a small NICU. By NICU, I mean, we had a tent where there were a lot of premature babies. Our logisticians created an incubator made from some of our packing containers, put some insulation in it, a light, a temperature control, and this is how we kept the babies warm. There's many other examples of resource innovation. Community involvement is something that you really can't have any sort of humanitarian intervention without the involvement of the community. And I think Matthias is going to talk a little bit more about community health workers and their role in contact tracing, education, and outreach, which the importance of that can never be underestimated. I will say that, in my experience, communication and transparency is what leads to trust. And this goes for communities both in the United States and then also abroad. So using community leaders, not just to deliver your message, but to create their own message and to be part of the decision-making process and to tell you what they think the issues are in their communities is really very important. So we've used religious leaders, village elders, elected representatives to be involved in decision making, and that's been very important, especially when you're trying to communicate with communities that have a large mistrust of the medical system or of outsiders. And never underestimate that communication is affected by language, culture, religion, politics, and gender. This picture right below that statement is a picture of just some traditional medications in Eastern Africa. And, working and kind of coordinating traditional medicine plus Western medicine and compromising about what can be used is something that, you do have to do in order to effectively treat patients. So the last thing I'm gonna touch on very briefly is mental health, also not to be underestimated. I think that the COVID pandemic has probably brought up a lot of things for a lot of people. Many people have probably not been in a situation like this before that's so stressful, and also one where you're potentially directly at risk as well just by doing your job. So the patient and provider overlap, I think, is important to think about. And then there's just overall stress related to medical impotence, the lack of resources, and then the sheer volume of cases and deaths. I think all of that can be difficult to process, especially while you're still expected to be working. I think both Tulane and LSU have psychological first aid available for providers, and I would encourage people to take advantage of that. Psychological first aid is just a way to address short and long-term like adaptive coping in situations of acute stress. And then also after stress. So, and this can begin during a crisis as well. So indirect effects like poverty, violence, economic disruption, all of this is going to compound the stress that you already had from the initial crisis. And there's also a concept of post-traumatic growth. So basically the idea that out of something that's very difficult, something good can happen. So I'm going to pass it to Dr. Iborico now.
Unmute. All right. Hello, everybody. Thank you for tuning in to our physically distanced grand rounds today. So I'm just going to start, if I can figure out here how to share my screen. I'm going to start with a little graphic. So let's see if this will work. So this is a website called World Mapper, and it takes the map of the globe and it changes the size of the countries based on different parameters. In this case, we're talking about coronavirus cases. So you can see where the epicenter was Wuhan in China, and then quickly it spread to Europe, Italy, Spain, and then the United States. And what you may not notice, I think if you pay attention to kind of South America, kind of like the Indonesia area, Indian subcontinent, and Africa, right at the end of the animation, I'm just right about here, I can't pause it, 13th, you start to see growth in those areas. So I think this map really highlights kind of that this is really a disease that goes from urban to rural and from rich to poor. So now let me see if I can, oops. Pull this up, review, and yeah, there we go. So I think in the United States, you know, we really started seeing this on April 6th. There was this article in the New York Times, coronavirus was slow to spread in rural America, not anymore. Maybe just a week or so ago, I saw some more articles about rural hospitals in rural Louisiana kind of seeing surges and starting to be overwhelmed. So as the curve is flattening, so to speak, here in a more urban center, New Orleans, I think it's good to be conscious that the pandemic is just kind of really starting to maybe take off in some of the rural areas. So taking it right to Compañeros en Salud. So for the last 2 years, like Dr. Bodeman said, I've been working, well, maybe a little under 2 years, but with Compañeros en Salud, kind of working mainly with their community health worker programs, just kind of supporting them as they transition to something called a household model. On the 8th of March, pretty recently, I traveled back there again. So at this point, there were 7 cases of COVID-19 in Mexico. They were all imported cases. There was no community transmission. All the contacts had been more or less traced, and there had been no further people who were identified as infected. By the time I came back 2 weeks later, there were 367 cases. And actually on the 9th, the day after I arrived in Mexico, was the first case in Louisiana, which was in New Orleans. And by the time I got back, there were over 1,000, I think somewhere around 1,100 cases. So clearly things changed very dramatically in those first days when I was in Mexico. So pretty quickly, things shifted for my role. Let me just do a little bit of background on Compañeros en Salud. So anything I say, by the way, is my own individual opinion. I'm not representing Partners in Health or Compañeros en Salud, but I'm going to talk about my experience there to kind of highlight a humanitarian kind of crisis arriving. and the work we did for that. So Chiapas is the southernmost state in Mexico. It's also the poorest state in Mexico. It's very rural, and it borders Honduras. Sorry, not Honduras, Guatemala, I believe, just to the south. We work in 10 communities, which are highlighted in the insert. The nearest one is about an hour, but everything is actually quite rural. So this is a picture of the area. So you can see it's the Sierra Madre, it's the mountains, it's coffee growing country. The access is quite difficult. So the town where Compañeros en Salud is based is about 3 hours south of the capital city of Tuxtla, which is the capital of Chiapas. And the roads are okay to get there, a lot of potholes. But then once you're there, it's a town of somewhere around 18,000 probably now. They have restaurants and they have kind of everything you need. But it is rural in terms of its access to things beyond a very basic community hospital and a basic health center. And then the communities that are near, so the nearest one, as I said, is about an hour. But then all the other ones are 3 to 5 hours on very bumpy dirt roads. The road you can see in this picture is pretty illustrative of kind of the lay of the land and how things are. So rainy season, things get washed out. It's very rural, very, very difficult for access. So what does Compañeros en Salud do? They have a program which started based in community health workers. So the upper left-hand corner is community health workers. That's our team in Laguna del Cofre, which is one of the 10 communities. And they pretty much immediately started supporting rural clinics and rural physicians who were going to do their rural service. So there's a program in many Latin American countries where physicians finish their training in medical school. As part of medical school, they do kind of an intern year, and then they are sent off to do a year of rural service. So this upper right-hand corner, this is me visiting in Capitan, one of the rural service physicians who's just to my right, and that's the nurse in the center to my left, and then one of the support staff to the far left of the picture there. And so, just kind of supervising rural medicine physicians and training and mentorship for them. So it's kind of like a mini rural medicine residency. So that's kind of how things got started. They support chronic care, mainly through the community health workers, mental health, a right to health program through referrals to higher levels of care that might even take people to Mexico City if they need to go there for certain things, and a maternal health where they have a labor and delivery unit that's run by nurse midwives. So that's kind of was the core of the program. But when I arrived there, things changed pretty quickly because of the surge in cases around the world of coronavirus. This is one of the staff members. He had symptoms very early on. We weren't sure. We thought it probably was not coronavirus just because of how things were, but he had traveled from Boston, which was relatively high incidence, to low incidence, rural Mexico. So we were very careful. You can see we're observing social distancing in this picture. We dropped off some medical equipment for him. He was tested pretty rapidly and it ended up being negative, but it was just kind of like an early kind of like, hey, we really need to be conscious of this even in rural Mexico. So what did Partners in Health do to kind of confront this issue? So I think that one of the things that they really focused on was thinking a lot about kind of trying to maintain a lot of the chronic health, not chronic, that sounds like illness, but kind of like the main basic access to health issues and the right to health that really kind of drives a lot of the work that Partners in Health does. And I just put up this quote from the UN High Commissioner for Human Rights, Mary Robinson, kind of just discussing what the right to health means. And so one of the things that we really focus on, so the AAAQ model is World Health Organization model for availability, accessibility, acceptability, and quality. And Partners in Health has kind of shifted that to talk about things that are necessary for provision of health in an equitable way. You need staff, you need stuff, space, systems, and social accompaniment. And so this is really going to play a role here when I talk about the COVID response, because all of this kind of foundational stuff really informed the response. So pretty quickly, Partners in Health started international meetings. Partners in Health works in 10 countries around the world, and in the United States, they're working in 2 areas, in Massachusetts, as well as in Navajo Nation. And so we started meeting on Teams every day, every morning, and kind of reporting the cases around the world, sharing the things that we were each doing as sister organizations. And I thought that it was just a really incredible example of collaboration using technology across a multinational organization. So these are actually the cases. This particular slide highlights Navajo Nation, which I think is really important, because one of the things that I think is really important to highlight is, we talk about global health equity. What is the E word? The E word is really, it's about no matter where you are, is trying to make sure that everybody has access, rich or poor, and that the poor generally suffer and don't have access. So focusing on them and low resource parts of the world. So even in Massachusetts, even in the United States, in Navajo Nation, there's still global health work to be done. So pretty quickly, Partners in Health came up with 4 objectives. This is our Compañeros en Salud slide, but here it is in English. So the 4 objectives for the COVID response were: 1, to protect patients, communities, and staff through safe testing, triage, and isolation. And this was kind of hinged on actually testing through rapid diagnostic tests. So these are both antigen and IgM, IgG tests. Currently, none have arrived in Mexico yet, but we expect mid-May that those tests will arrive, and we have protocols that are actually publicly available through the Partners in Health website. There are different manuals for COVID response, and under the testing, tracing, and tracing manual, it's kind of described a little bit about the approach for rapid testing. The goal fundamentally is to have everybody have access to PCR tests, because those are the gold standard, so to speak, even though that's not always the most sensitive because of where you're sampling probably, and where the virus actually is. But we want everybody to get PCR. However, in many resource limited and rural environments, Chiapas being one of them, there is very little access to testing with PCR tests. And the reasons for this are multiple. Global supply chains, as you all know, and as Dr. Don kind of highlighted, are struggling. And as the rich countries often suck up a lot of the resources, it's been much more difficult for countries that are under-resourced to kind of compete against this and get access. And then, as everybody or as many people are probably aware, President Trump put in a ban on export of PPE. And there were some shipments that were destined for rural Chiapas via PIH, and those were put on hold as well. Relatively recently, those restrictions were loosened, but that definitely affected our ability to access this early. The second objective, to provide dignified, high-quality treatment for people with COVID-19 and all patients. So one of the things that we really worried about and we still worry about, is the access to regular healthcare. People with diabetes accessing insulin, people with heart failure accessing their heart failure medications, people who are having emergencies, potentially obstetric emergencies or traumas, accessing care, especially in our very rural communities. And so kind of maintaining those lines open and making sure that we were still providing high quality treatment, even in the midst of a pandemic, was one of the things that, that we're focused on. Point 3 was accompaniment of Ministry of Health colleagues to support government response. So this is something that's an ongoing kind of thing that we do, and we're in the process of different kind of working on different agreements with the local ministries of health, supporting them for testing, supporting them for contact tracing, for suspect case investigation, And one of the things that we do is we actually work very closely with the person who is now the head of the local referral unit for COVID-19. I'll show you a picture of that in just a little bit. And then the fourth point, which I've been more recently involved in pretty heavily, is mobilizing strong contact tracing system via the network of skilled community health workers that we have. So Partners in Health was always, since its inceptions in Haiti and Boston, kind of grounded in an idea of accompaniment and accompaniment via community health workers. And that's something that has always been a strength in all the programs that Partners in Health has, including Compañeros en Salud. And as I was involved in kind of strengthening and modifying that model very recently, this came to the forefront. So what's the first thing that we did locally? So we came up with kind of two things that were important. One was infection prevention control, because we really needed a team. Really kind of has become more of a team for the COVID response, not just infection prevention control in the traditional sense of, you know, PPE and disinfecting surfaces and flow, that kind of thing. It's really been a team kind of that has been sort of leading the COVID response. So that was the first thing. So I helped as an interim coordinator of that and kind of putting together the team. At the very bottom in purple, we thought supply chain was kind of a critical part. So we have a person who's dedicated to supply chain and kind of coordinating with the headquarters Partners in Health team in Boston, and kind of making sure that we try and get access to everything that we need for the stuff that's needed. The second thing we did is sit down pretty quickly to kind of map out our community, both in terms of staff that was needed, in terms of the spaces that were available, and in terms of kind of how we were going to structure the systems, or maybe restructure some of the existing systems. So one thing that we identified early on was that it wasn't just about the infrastructure of the hospital or the health center or the Casa Materna, which is the nurse midwife led labor and delivery area. But it was really also about the community. So we set up two positions, one for communications in the local community in Jaltenango, which is the town of about 18,000 people, to really kind of coordinate with the president, with the ejidatarios, which is sort of like a leadership group that deals with a lot of the land ownership issues, which is kind of is actually unique to Mexico. For another day, it's a very interesting topic. And then the community itself, in terms of just public health education campaigns, setting up appropriate hand wash stations, making sure everybody kind of was informed that we were addressing a lot of the myths that were arising about COVID-19. And then kind of at a higher level with the Secretary of Health, which there they call the Secretary, which is the Ministry of Health for the state, for their COVID response. And then as well as interfacing with all the rural community leadership and making sure that we had access, that the access was acceptable to the communities, and that they are involved, and that we have transparency in everything that we're doing. So that was sort of the plan. So kind of to talk about some of the things that that came up along the way. I wouldn't call them problems, just the things that we're dealing with to try and resolve and improve the response to COVID. Oh, I should pause actually. So all this is pre-COVID. As I was talking about earlier, rich to poor, urban to rural. While COVID-19, the pandemic, was raging in the north of Mexico and in the center, in the capital, we really didn't have any cases, or we thought we had 0 to very few cases in rural Jaltenango. And this whole time, up until really a week ago, we were pretty sure that there was no community transmission. And we had been able to actually pretty much isolate people who were traveling from the north with some success. We are not the Ministry of Health. We are not the local authority. We work in conjunction with them. We support them. And so we give recommendations, but we're not able to force anybody to stay at home. So we're doing the best we could. And really up until a week ago, and I'll talk about that here in just a minute, we didn't actually have any cases. So this gave us a lot of time to plan and prepare. So this is, I think that maybe Alfred, he's our kind of infrastructure communications kind of person, IT person, and he is holding up an antenna. So that antenna is critical This is our office in Quetzaltenango. And it allows us to communicate with all of our rural communities, as well as all of the trucks that are traveling back and forth. And it's vital because if the rural medicine physician has a question they need to ask about a treatment, they can call in through the radio, because there is some limited internet, actually, interestingly enough, but no cell phone access in any of these rural communities. So they can call in for that. If there's an emergency and somebody needs to be evacuated and come down to Quetzaltenango, they can let us know. So it's really a critical lifeline. So making sure that that is set up and functioning everywhere is one of the things that we identified early as a critical part. So I was talking about kind of spaces and systems. So this is a picture of the hospital, which is one of the first areas that we started to really talk about a lot. And you can see that there's a hand washing station. So the community and the local authorities actually helped set this up in conjunction with the director of the hospital and some support from us. And so this is right at the entrance, and this is a triage point for the hospital. And then if you were to walk into those gates and go to the right, you would go around and there's a respiratory illness clinic where we do kind of the triage for this. And then if you don't have any symptoms of a respiratory illness and don't have any fevers, you can go into that waiting area, which is here. And if you look, you can see that there have been taped off chairs, and that's for social distancing, so that we can have people be distanced as they're waiting. Also, we wanted it to be outside so that there's airflow and there's air changes, so the virus isn't hanging out in the air, lower risk of transmission. So social distancing has been a big issue and a lot of debate. The World Health Organization says less than a meter. Partners in Health thinks that probably less than 2 meters is more appropriate. And I think a lot of other places around the world think that less than 2 meters is probably more appropriate. Some people say 1.5 meters. So it's actually sort of highlights that we still know very little about this disease and kind of how to keep ourselves safe, although things are evolving. And we have lots of prior pandemics and infectious disease outbreaks to kind of we've learned from and are able to sort of apply. So just kind of an interesting point of some of the things that get operationally kind of discussed, like, should we do 1.5 meters? Can anyone really tell the difference between 1.5 and 2 meters? How do we keep people distance? So this is, when we be conscious of time, want to leave time for questions, but this is one of the hospital wards. So we were just kind of thinking about physical spacing. Those are cloth drapes, so changing the drapes to plastic, something that can divide people for both privacy as well as things that can be wiped down and be barriers. So there are 2 wards like this, each of which are set up to take 8 people in the local hospital, and thinking about how we can put more people and kind of divide one ward and do cohorting. So stuff, PPE. So these are all donated 3D printed face shields. So it's actually luckily been one of the areas that we've been able to really kind of get local supply chains going to have access to face shields. And then PPE, this is a donated Tyvek suit. This is my friend Sebastian Moar. He is the director of the COVID referral unit now. And he's just modeling some of the donated PPE. But I think this is actually one of the areas that's been the toughest to find is surgical masks and actually gowns. And we've seen that also in our hospitals in the United States. Imagine trying to get all this stuff in rural Chiapas is an additional challenge as well. So I put this slide in to remind myself, oxygen. Oxygen is a critical issue, and we expect many, many patients, the majority of patients probably, to need oxygen and hopefully not need to be intubated. And so supply chains for oxygen are critically important. We hope to have oxygen concentrators that can do up to 10 liters per minute flow in the hospital, and 1 in each rural community. But then the debates about how to keep people at home in rural communities where it may be a 4-hour drive to get to Quetzaltenango. And then the debate about whether or not we intubate anybody. So decided that the risks of intubating somebody in an area where we don't have respiratory therapists, where we don't have critical care physicians, are too high, and that we're going to do the best we can to keep people from needing to be intubated, and that if we feel like they are verging on the point where they may need to be intubated soon, that we immediately evacuate them to Villaflores, 2 hours away, which is where the COVID referral center is. So this is Villaflores. big blue arrow there it indicates where the COVID-19 ward is. So this is set up to be both an isolation ward for kind of cohorting of COVID positive patients who might be needing higher levels of care, so like oxygen or maybe high flow. And as well as part of it has been dedicated to be an ICU level care with ventilators. Also there are plans for expanding into the actual hospital building, which is part of which you can see to the right of the picture. So there, there's ability to ramp up to 60 beds, I believe, quite quickly. And so we're now working to kind of help support their planning and coordination at the referral unit. So back to our rural areas, we had to kind of restructure how things were, because if you can see, this is the clinic, and inside of those windows is the waiting area. That's not so great for COVID-19. You may be spreading coronavirus if you have people wait in a little room like that. So this clinic is not actually a great example. This one is a little bit better. This is Laguna del Cofre again. And you see there's like a little bit of a cover and there's space outside. So airflow, we can tape off chairs. We can have more seating around the back where there's some shade, and kind of try to set up waiting areas for people, as well as dividing flow. So we wanted to have people who were symptomatic respiratory illnesses divided, and that those flows should be as separate as possible and unidirectional. Another kind of waiting area that we were setting up. And then contact tracing. So I think I'm running short on time, so I'll be brief. But sort of one of the last things we're talking about in terms of systems and ways to kind of head this off is probably the importance of strong contact tracing. So we won't be able to be 100% effective unless we're able to really partner with the local governments. But as a pilot, we've started a week ago, we started really in earnest planning our contact tracing model and our protocol. So I'm in a coffee shop in Tuxtla, pre-COVID really being present, which is where many of the coffee growers in our rural areas send their coffee. It's a cooperative. And that's Doña Katy, who I'm pointing to. She's a local celebrity because she's featured in the coffee shop there. And she's one of our community health workers. And the things that we struggle with almost immediately with our contact tracing was staff. We realized that people like Doña Katy, who is older, were actually high-risk individuals. So the ethics of putting some of those people on the front lines. So we were actually left with a lot fewer community health workers, was one of the challenges. And then the stuff, providing community health workers with appropriate PPE and the right training and the systems that they needed to be able to do their work. This is from the Partners in Health. It's publicly available guide for contact tracing. So a case of COVID-19 is diagnosed. So that very quickly became another issue because we don't have good access to testing for supply chain reasons. And so trying to get rapid tests there. And before that, doing a syndromic approach to who has COVID-19, which has been a huge debate. And we actually have a big meeting planned tomorrow. Like, what is our case definition? If you look around at different countries, every country has a different case definition, from like any symptoms of anything to things that are more restrictive, from like must have 1 of cough or fever plus 2 of fatigue and myalgias or something like that. It's very challenging because it's we know that there are many mild and potentially asymptomatic cases. So like and also limited resources as to how we access these people. The things that are easier probably are like designing the plans for quarantining, and hopefully for eventually testing and lifting quarantine based on either a testing paradigm or a symptomatic paradigm. So if they're free of symptoms for a certain amount of time, that they should be free to go. And then this is all nice in planning, but it's challenging in execution. We're about to start that. The other part of this is all data management. So we want to know all the cases. We want to know where they are. We want to know where they're moving, who their contacts are. And so we're utilizing ComCare and Power BI, which is a Microsoft program, to kind of set up dashboards and control the flow of information. So this last slide, also with those dashboards we can share with the local authorities. Okay, so I think this is my last slide. Just to highlight the work that Partners in Health is doing in Massachusetts. So this is a New York Times article highlighting that work. So an army of virus tracers. So Massachusetts is currently the only state in the United States to actually to be taking this very seriously and trying to do in high intensity contact tracing in partnership with Partners in Health and their significant experience over the years with similar things, cholera in Haiti after the earthquake in 2010, the hurricane in 2010, and then also extensive experience with Ebola in Sierra Leone and Liberia. So in any case, they've partnered and it's a very interesting collaboration. So it's part of our global health equity focus that, no matter where you are in the world, this stuff is important and it's all still global health. And I think that's where I'm gonna wrap up.
I want to thank both Dr. Dand and Dr. Iberico for the sobering presentation. That's why it's called a pandemic. We have a few minutes for maybe a few questions. If you have any questions, please type it quickly. I'll read it to the presenters. And while waiting for some questions, if any, I'll start with one and maybe both of you can answer. With these limited resources, one would expect perhaps higher mortality with this epidemic in these parts of the world. Is that the case? Do we have any preliminary figures how they are handling this?
So Monica, do you have any responses? I have some.
Yeah, I don't have any data right now about the mortality rates in different countries. I think there's probably a lot of factors that go into that. A lot of talk about the age of the countries, and in addition to what resources are available. Matthias, I'll let you add on to that if you have anything else.
Okay, Dr. Iberico, question to you: how many cases of COVID-19 are present in Chiapas now?
So, so just to kind of tag on to the first question. So I think one of the answers we don't know. We expect higher mortality rates in these areas. There is a lot of hopeful stuff coming out about how different the ARDS is that's caused by the virus and how we may actually be able to avoid intubation for a lot of patients. So if that is really pans out to be true and we're able to use a lot of kind of non-intubating modalities for treatment, such as proning and high flow nasal cannula, non-invasive ventilation, like we may be able to have a pretty high impact. But a lot of the concern in Mexico is also that the population, there's a lot of obesity, a lot of chronic illness. And so I think we are very concerned that the mortality rates will be higher. How many cases? So I missed the morning meeting today. I can tell you that it is in the hundreds, I believe, right now, but that but it's almost certainly way higher than that. Mainly the issue is that we just don't have access to adequate testing to know how many cases there truly are. So right now in rural Mexico, where Partners in Health works, where Compañeros en Salud works, we're pretty certain a community outbreak in one of the communities in terms of how many people are affected and who has COVID-19 and who doesn't. It's very hard to say. So that's where this kind of case definition comes into play. But I couldn't tell you if there are maybe hundreds of people. The other aspect of this, and that plays into the mortality calculation, is how many asymptomatic or mildly symptomatic people there are. So there's also more information coming out about that recently with some prevalence studies that shows that maybe the rate of mild and asymptomatic is very high, and which would bring your mortality numbers actually down. So there's a lot still to figure out.
Okay, thank you. We have time for one more question. The question is, any data on bubble CPAP in adults? I guess this is for Dr. Iberico.
That's very interesting. So we're talking about a lot of things. So one of the concerns that we have is about spread and risk to healthcare personnel. So we're currently not doing any non-invasive ventilation techniques. And the Villaflores Center is high resource enough that at least at this point, we've had no patients who have needed to be ventilated, but they are able to use just normal CPAP machines in their isolation area, as well as just, use kind of the same standards here. But that's a very interesting question. I don't know any more than that. So.
Okay, Dr. Dand, any comments on this?
Yes, I also don't have any data on bubble CPAP in adults. I don't know whether or not you'd be able to generate enough pressure from bubble CPAP to make it effective for an adult. It's usually used in, in children, newborns, but very interesting. And then, of course, like Dr. Iberico mentioned, the risk of using CPAP in places where you might not have the appropriate PPE is also important to consider.
Well, thank you very much. This brings us to the end of our time. I want to thank our speakers, Dr. Dand and Dr. Iberico, and all of you who joined us online. And have a good day, everybody. Thank you. Bye.
Thank you. Bye.
Thank you.